what I think all important is just to give you a tiny bit of context before I get to what we're doing together. So, because as you've just described, the system is complex. So the Northwest Neonatal Operational Delivery Network is a mandated network. That means it's nationally prescribed. So that means there are these networks across the whole of the country. And that was because there seemed to be a need to make sure that we had coordinated pathways for our sickest and most vulnerable patients, I would suggest, in any hospital, which is our very sick neonates. So as well as supporting commissioners and providers and our parents as part of this national programme, we're also working obviously to support the LMS and working within the LMS. So although I've got a lot of information there, I'm going to home in on what we're doing in Lancashire and Cumbria. So even though we've got a title, the Northwest, the actual Northwest Operational Delivery Network is made up of 3 networks, which is Greater Manchester, Cheshire and Mersey, and Lancashire and Cumbria. And that's to ensure that we've got a local focus here in Lancashire and Cumbria. So a lot of this work we're doing across the whole of the Northwest, which is really, really important, because challenges in Lancashire and Cumbria are very similar to the challenges we've got in neonatal care in Cheshire and Mersey and in Greater Manchester. So there's something about doing something together as a bigger system, but recognising that we also will have to work in local systems to ensure that we're getting it right for the local people of that conurbation. So I'm not going to go into detail into all of this, but just to say there's so much work going on in relation to neonatal care, and I can't emphasise enough, they are some of the most sickest and most vulnerable patients in any hospital. So, in Lancashire and South Cumbria, obviously, as part of the local maternity system, what we set out was what are the things that we need to do together in relation to improving either the services or the quality of neonatal care. So, some of the things that we want to make sure that we have in place is joint policies. So, how can we connect maternity and neonatal services together through that perinatal period, which is really, really important. Also, as part of neonatal care, unfortunately, some babies do need to move from where they were born to intensive care units. Because we can't deliver neonatal intensive care everywhere, because it's a very specialised service, we have to move babies from one area to another. Now, often we will try and ensure that mothers are in the right place to give birth, that will optimise the outcomes for their babies by delivering them in a unit that has a neonatal intensive care. So what's really important is that we understand where our babies are being born when they are sick or needing neonatal care, and where our units are that are going to deliver that, and make sure that we've got the cots in the right place to look after these sick babies, but also for babies that can be cared for closer to home. So a big part of our work is about optimising capacity and making sure that we know where the babies are, where the cots are, and if they are serving their local population and they are in the right place. As I said before, unfortunately we do have to move some babies. So what is vital is that our transport service can move our babies efficiently and effectively across the conurbation. And for Lancs and Cumbria, that might mean in Lancashire and Cumbria, but also might mean to Liverpool or Manchester. So we've done a lot of work around the neonatal transport service. Workforce we've heard a lot about today, and of course it's absolutely vital that we've got enough nurses, we've got enough doctors, that we're able to deliver that very specialised care to babies. And of course, we've always, all of us are looking at quality improvements. How can we improve our services? How can we improve the care that we're giving? And the big piece of work that we've got a workshop here, and I'm going to emphasise a little bit more on, is that reducing the number of babies separated from their families. So this is a little bit what I've just been talking about. The joint policies, so one of the things that we've done already is we're just going to ratify that through the next LMS meetings, is an in utero transfer policy. And what that means is when we identify that a woman may need to move because she may be having a baby that requires neonatal intensive care services, that we've got a system to do that across our LMS and across the Northwest. So that's now in its final stages. And what that will do is ensure that we've got, that we're all doing the same thing, that we're all saying the same thing, and that we're only moving women that really need to move. And if we do move those women, what is the outcome? Has that woman then gone on to deliver, or has that woman stabilised and been able to be transferred back to local care? So in the activity capacity and demand, which is where we collect the information about where the activity, where's babies being born, where do those babies need to be. So this is some of the work that we've done, and again we're going to be sharing this with all providers and through the LMS. Is what we're finding is that babies born near their due date, or soon after or soon before, there's an increase, unfortunately, in Lancashire and Cumbria of those babies being admitted to hospital. Now, for some babies, that would be the right thing. They are sick. But for other babies, they may be able to be cared for next to mum in a transitional care area on a postnatal ward. So that's something that we're looking at through the work programme, through the reducing the number of babies born. The number of babies, on a really positive note, so the number of babies born in the right place, so where we know that mums are going to deliver a sick baby, that's really high for Lancashire and Cumbria, so we're getting that right. If we compare ourselves to some of the rest of the country, in Lancashire and Cumbria, 90% of our babies are born in the right place for neonatal intensive care. If we look at places like the West Midlands, only 60% of their babies are born in the right place. So we're really getting that right in Lancashire and Cumbria. The birth rate doesn't seem to be, we're not in a baby boom, it doesn't seem to be going down, it doesn't seem to be going up. There seems to be quite a plateau in relation to the number of babies born. And that's really important because we need to make sure that we've got services that can deliver the services required for women. So we need to understand what the birth rate is doing, so we need to be able to plan. The other unfortunate thing about the work that we've been doing in relation to gathering activity is demonstrated that we have got a deficit in nurses in neonatal care. Now, I'm sure we'll be saying the same in maternity care as well. But we're not meeting workforce standards in neonatal care, and that's a real challenge to us. So we're doing a lot of work to understand how could we do things differently, how could we utilise non-registered staff, how can we use therapists, how can we use allied health professionals, how can we do things differently. So that's a big piece of work that we're doing across the whole of the Northwest, but also specifically in Lancashire and Cumbria. So the thing that I'm going to finish on, and obviously to give you a taster for the workshop, is, as I've said, 10%, so 1 in 10 babies may need to be admitted to a neonatal unit. And unfortunately, 50%, and sometimes more than 50% of those babies are around the due date. Some of those babies absolutely need to be admitted to hospitals, need to be admitted to neonatal units, but many of them could be cared for with mum and would not need to be separated. This has been recognised nationally. There's been so much work done about this, and there's so much resources for midwives and nurses. So we know that we can make a difference. And why I'm just demonstrating this is this is the variation in admissions of babies on or around the due date. And so we can see here from 2.1%, the green is Lancashire and Cumbria, and I just want to celebrate the fact that Lancashire and Cumbria are on this side of the graph, which is brilliant. But we've got some units that are here at 10.5%. Huge variation, which again demonstrates that actually what is this unit doing here that this unit could learn from? What is the right? What is right here? Well, I don't think we can say what is right. All we can say is that we know this is fantastic, looks fantastic, and this doesn't look quite right. So how do we learn? How do we learn from each other? So the reducing the number of babies separated isn't just about babies on or around term. And the Attain programme that you've heard about, it is about that work. What we're doing is stretching ourselves a little even further. We're saying that there are babies born at maybe 34 weeks, 35 weeks and 36 weeks gestation that may be able to be cared for with mum or next to mum. So stretching ourselves a little bit further, which of those babies could we add some support to and care for babies next to mum, either in transitional care or in the postnatal area. So our ambition is quite big, but actually, as we said many times today, this work, the evidence around this work, and this work is already being done either in Lancashire and South Cumbria or elsewhere. So it's not an impossible task. We actually can reduce the number of babies separated from their mothers and families. But it does take a coordination of both maternity and neonatal services, but also a system-wide approach to reduce variation and to learn from each other on how we could achieve our goal of reducing the number of babies separated. Thank you.
Hold on. One question from Angela. Hold on.
Hi, Julie. Yeah, transitional care is absolutely the way to go forward, and it's what we do. But the funding of and the commissioning of transitional care is the white elephant in the room. If the baby's in NICU, you'll get paid. If the baby's on a postnatal ward, you don't get the funding. So is that part of all this wider debate? Because you probably may find the figures, if you move the funding, you'll move the figures, but then it's like a chicken and an egg.
Transitional care is absolutely part of the work that we're doing around reducing the number of babies separated. There's already fabulous work being done on the creation of transitional care, and obviously the CN, I forgot that acronym, but your incentive, your insurance scheme incentives has made that happen. Yes, I can't see. It has made it happen. There is funding for transitional care. Some aspects of transitional care. Some providers are not aware that they can get that funding, and other providers are aware of that funding. So we're working with commissioners to actually ensure that transitional care is part of any neonatal tariff or pricing scheme going forward. So we are doing that work, but even before we finish that work, there is transitional care funding available if you know where to go. For me, I think it's also about how do we have a universal offer to all women so that we can offer that to all women. Whatever that, it might look differently from one unit to another, but I think the universal offer needs to be there. And we as a system need to understand how we support providers to get the funding, but also how we create the sustainable funding going forward.
Thank you.